Enzimatic vitreolysis with ochriplasmin has been approved for the treatment of focal vitreomacular tractions and macular holes inferior to 400 microns. However, when it is not effective, a vitrectomy is required. Our experience with Vitrea includes 16 eyes, and in 9 the therapy was unsuccessful. In this video, we present our surgical findings in cases of therapeutic failure. The first case is of a vitreomacular traction that did not release after treatment with ochriplasmin. As we can observe, there is an anomalous posterior vitreous detachment. Injection of triamcinolone allows us to better visualize the vitreous, observe in detail the vitreoretinal interface, and locate the traction areas. As we can see, there is a remarkable difficulty in releasing the vitreous cortex adhering to the macula and papilla, in this case made easier by using a membrane forceps. After the release of the vitreomacular traction, we found additional lamellae of vitreous cortex. In the postoperative period, we could observe an almost complete recovery of the normal structure of the fovea. In our second case, we once more have a focal vitreomacular traction and a foveal pseudocyst, also without release after ochriplasmin injection. Here again, we can see lamellae of the vitreous cortex, strongly adherent to the macula and the optic disc. Removal with the vitrectome is facilitated by increasing the vacuum and aspiration parameters. In the postoperative period, we confirmed the complete release of the traction on the macula. The third case we present is of a patient with diabetic macular edema and a vitreomacular adhesion. In this case, only a temporary regression of the edema was achieved without releasing the traction. After injection of triamcinolone, we also used the dye membrane blue dual and performed the peeling of the internal limiting membrane in a centripetal way, trying to preserve the structure of the fovea. After the intervention, we noticed a marked structural improvement with the disappearance of the retinal cysts. Cases 4 and 5 are of 2 patients with a macular hole with traction, an indication for chytria. After the injection of ochriplasmin, the traction did not release, although there was an apparent progressive closure of the macular hole. The persistence of traction with subretinal fluid and the aggravation of visual symptoms motivated our decision to perform the vitrectomy. We now observe the surgery of the 5th case, where we clearly were dealing with a pathological detachment of the vitreous. In fact, recent studies point to the presence of vitreous schisis in up to 50% of patients with a macular hole. We performed the remaining procedure as we usually do for macular holes, peeling the internal limiting membrane and performing an internal tamponade with SF6 at 25%. Postoperatively, we confirmed that the traction was released in both cases. Despite the loss of follow-up of the 4th case, serial OCTs of the other patient revealed that, after 1 year, a complete resorption of the subretinal fluid was achieved. In conclusion, in all our surgical cases, we confirmed the existence of an anomalous posterior vitreous detachment and the presence of multiple adherent lamellae of vitreous cortex. Our experience is in line with recent reviews on the good prognostic factors for enzymatic vitreolysis. Our findings illustrate the need to better understand the vitreoretinal interface in these patients, and OCT currently provides the best structural images. Future in vivo studies with high-resolution OCT may be the key to clarify the pathophysiology of vitreoretinal diseases.